Yes, sir. Three, two, one, start.
Thank you. So, a very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a class on upper urinary tract trauma, and this would be presented by our resident, Dr. Keshav, and would be moderated by our faculty, Dr. Somendra BANSAL. So, I would request Keshav to kindly share his presentation.
Good morning, everyone. Genitourinary trauma, seen in both sexes in all age group, but is more common in males between 15 to 45 age group. Kidney is the most commonly injured organ, and it represents 5% of all trauma cases and 10% of all abdominal trauma cases. The location of trauma is kidney is the most affected organ, and second one is the bladder. It is divided into blunt renal trauma and penetrating. Blunt injury results from the road traffic accidents, injury, fall, sports injury, and assault. The kidney and or hilal structures are directly crushed as a result. Less commonly, sudden deceleration may result in an avulsion injury affecting the vascular structure of the hilum or the uretropelvic junction. Penetrating injury are due to stab and gunshot wound. They tend to be more severe and less predictable than blunt trauma. The most commonly used classification system is that of American Association for Surgery for Trauma. It is a CT-based classification. In grade 1, there is a subcapsular non-expanding hematoma or parenchymal condition without parenchymal laceration. In grade 2, non-expanding perirenal hematoma confined to gyrota fascia and laceration less than 1 centimeter depth. In grade 3, laceration more than 1 centimeter, less than renal laceration less than 1 centimeter depth without collecting system, more than 1 centimeter depth without collecting system rupture or urinary extravasation. Any injury in the presence of a kidney vascular injury or active bleeding contained within the gyrota fascia. In grade 4, parenchymal laceration extending into the collecting system and there is a urinary extravasation, renal pelvic laceration or complete uretropelvic disruption. In vascular segmental renal vein or arterial injury, active bleeding beyond gyrata fascia in retroperitoneum. In grade 5, shattered kidney with loss of identifiable parenchymal renal anatomy and main renal artery or venous injury. The evaluation of renal injury, the evaluation of a stable patient with suspected renal trauma is now based on the trauma protocol CT scan. It is done before the involvement of the urologist by the trauma team. Indicators of urinary indicators of injury include a direct blow to the flank or rapid deceleration event. Special consideration should be given to the pre-existing renal diseases or the injured solitary kidney. Pre-existing abnormality like hydronephrosis makes an injury more likely following trauma. A physical examination may reveal flank bruising, stab wounds, or bullet entry or exit wounds, and abdominal tenderness. Urine analysis and hematocrit and baseline creatinine are required. Hematuria, visible or non-visible, is the key finding. The best predictor of significant urinary system injury includes the presence of microscopic hematuria or a positive dipstick test or gross hematuria with hypertension, systolic blood pressure less than 90 mmHg at any time of resuscitation. Degree of hematuria and severity of renal injury do not correlate consistently. Gross hematuria has been observed in the minor renal conditions, and microscopic hematuria has been associated with severe renal injury. Approximately 50% of injury to the uretropelvic junction has no microscopic or gross hematuria. The first delegate of urine obtained either by catheterization or by voiding should be used to determine the presence of hematuria. And because the later urinary sample are often directed by diuresis from resuscitation fluid, result in an underestimation or absence of hematuria. Radiological imaging, the goals of imaging are to grade the renal injury, documents the pre-existing renal pathology, demonstrate presence of the contralateral kidney and identify injury to the other organs. In patients who have not had any imaging, the indication for the renal imagings are a visual hematuria, non-visual hematuria, and one episode of hypertension, a history of rapid deceleration injury, uh, significant associated injuries, and penetrating trauma. Clinical signs suggesting renal traumas are flank pain, abrasions, fracture rib, abdominal distension. Ultrasonography is the primary survey of a critically injured patient. Focused assessment sonography in trauma is used to identify hemoperitoneum as the cause of hemorrhage and hypovolemia. However, it is not routinely used for solid organ injury, and because it is insensitive, operator dependent, and does not define the injury well, though it is an option for follow-up. CT is the imaging modality of choice in stable patients. Establish the presence of contralateral kidney and demonstrate concurrent injury to the other organs. It is ideally performed in three phases: arterial phase, nephrogenic, and delayed phase. Delayed phase is most important because it identifies collecting system or ureteric injury. CT findings suggestive of major injuries are medial hematoma, suggestive of vascular injury, and urinary extravasation, suggestive of renal pelvis or uretropelvic junction avulsion. Lack of contrast enhancement of the parenchyma is suggestive of arterial injury. Venous injuries are on CT. CT is inability to define a renal venous injury adequately. Medial hematoma accompanied by following findings are suggestive of venous injury, like normal arterial perfusion, normal parenchyma, and contrast material in the collecting system. Single shot IVP, limited role but important role intraoperatively. Indications are unexpected retroperitoneal hematoma surrounding kidney during abdominal exploration. The purpose to assess the presence of a functioning contralateral kidney and to radiographically stage the injured site. Only a single film is taken after 10 minutes of IV injection of contrast. If findings are not normal or near normal, the kidney should be explored to complete the staging of the injury and reconstruct any abnormality found. This is the normal single shot IVP. There is a this is single shot IVP showing the extravasation of urine. Renal arteriography, both diagnostic as well as therapeutic, used to define arterial injury suspected on CT or to localize and control arterial bleeding. Useful in the primary setting with persistent bleeding in a hemodynamically stable patient. Pseudoaneurysm and arteriovenous fistula are treated by angiographic embolization to stop secondary hemorrhage. Superselective embolization therapy, effective, minimally invasive technique, and avoid unnecessary exploration that could otherwise result in a nephrectomy. This is arteriography demonstrating the complete occlusion of the left renal artery. Non-operative management, the stepwise approach starting with the conservative treatment followed by minimal invasive or surgical exploration has become the standard of care in hemodynamically stable, well-staged patient with American AST grade 1 to 3 renal injuries. Grade 4 and 5 injuries are more often require surgical exploration, but even these high-grade injuries can be managed without renal operation if carefully staged and selected. In blunt injuries, primary conservative management is associated with a lower rate of nephrectomy and no increase in immediate or long-term morbidity. Grade 1 to 3 injuries are managed non-operatively. Grade 4 injuries are also mostly treated conservatively, but the requirement for subsequent intervention is higher. Grade 5 injuries often presents with hemodynamic instability and major associated injuries. There is a higher rate of exploration and nephrectomy. In a unilateral main arterial injury or arterial thrombosis are normally managed non-operatively in hemodynamically stable patient. Surgical repair is reserved for bilateral artery injury or injuries involving a solitary function kidney. Pre-hospital prolonged warm ischemia usually results in irreparable damage and renal loss. Factors which increases the risk of intervention are hematoma size more than 12 centimeter, penetrating trauma, vascular contrast extravasation, pararenal hematoma extension, concomitant injuries, and shock. Penetrating injuries are a majority of low-grade step wounds posterior to the anterior axillary line can be managed conservatively in a stable patient. A gunshot wound is an independent risk factor for nephrectomy in grade 4 or 5 traumatic renal injury. This is a guide for decision making. In blunt trauma, there is if hematuria microscopic or a gross hematuria. In microscopic hematuria, selective renal imaging and patient can be put on follow-up. In gross hematuria with shock, if patient is stable, CT scan is done, and if it is a grade 3 to 5, selective renal exploration can be done. And in unstable patient, the abdominal exploration with single shot IBP, or if it is a abnormal or inconclusive, renal exploration must be done. In penetrating injuries, if there is a hematuria microscopic or gross hematuria, if patient is stable, the this algorithm can be followed. Selective angioembolization. This is an accepted CT finding indicating the need for angioembolization or active extravasation of contrast, AV fistula, and pseudoaneurysm. The presence of both active extravasation of contrast and a large hematoma predicts the need for angioembolization. Most beneficial in the setting of high-grade renal trauma. Gross hematuria, hemodynamic instability, grade 5 trauma, and urinary extravasation are significant predictor of angioembolization failure. It can be successfully done in up to 94% of grade 3 trauma and 89% of grade 4 and 76% of grade 5 injuries. The evidence supporting angioembolization in penetrating renal trauma is sparse, and one study found that angioembolization is 3 times more likely to fail in penetrating traumas. Stenting and urinary catheterization. Current evidence suggests interventions like stenting, nephrostomy, or perirenal drainage is only when patients develop symptoms like flank pain, fever, leukocytosis related with persistent urinary leak. Catheterization is not necessary in stable patients with low-grade injury. And patients with severe visible hematuria who require monitoring or stenting benefit from catheterization. Repeat imaging in renal trauma is also recommended in high-grade injury and in penetrating trauma 2 to 4 days after trauma to minimize the risk of missed complication. Repeat imaging can be safely omitted for patients with grade 1 to 3 injuries as long as they remain clinically asymptomatic. Nuclear scintigraphy before discharge from the hospital is useful for documenting functional recovery. Surgical management, the expanding and or pulsatile perirenal hematoma at laparotomy. The indication for surgical management are hemodynamic and unstable grade 5 vascular injuries. And the transperitoneal approach is followed for surgery, entering the retroperitoneum and leaving the confined hematoma undisturbed within the perirenal perinephric fascia is recommended. Temporary breaking the fossa tightly and laparotomy bed with laparotomy beds can salvage the kidney in instance of intraoperative hemorrhage. Access to the pedicle is obtained either through the posterior parietal peritoneum, which is incised over the aorta, just medial to the inferior mesenteric vein, or by blunt dissecting along the plane of psoas muscle fascia, adjacent to the great vessel, and directly placing a vascular clamp on the hilum. Obtaining early vascular control before opening gyrota fascia can decrease the renal loss. Feasibility of blood loss. Feasibility of renal reconstruction should be judged during the operation. Rhinorrhaphy is the most common reconstructive technique, and partial nephrectomy is required when non-viable tissue is detected. Partial nephrectomy when polar tissue cannot be reconstructed. This is the approach to the renal hilum before opening the gyrota fascia. In rhinorrhaphy, closure of the pelvis and ligation of vessel is done, and the defect closed over the gel foam bolster. This is the image showing partial nephrectomy. The omental pedicle flap are sutured to the pole of kidney. Renal artery thrombosis occurs secondary to deceleration injury. The mobility of kidney results in a stretch on the renal artery, which in turn causes the arterial intima to disrupt. The consequent thrombus occlude the vessel and rendering the kidney ischemic. They diagnosed by CT or angiography, immediate renal exploration in the appropriate candidate in an attempt to salvage the kidney. With delayed diagnosis, more than 8 hours, the kidney typically cannot be salvaged. The damage control surgery, the wound and area around the injured kidney are packed with the laparotomy pads to control bleeding, with a planned return in 24 hours to explore and evaluate the extent of injury. Useful in patients with extensive injury along with complex renal injury to avoid total nephrectomy. The complication of renal trauma. Persistent urinary extravasation can result in urinoma, perinephric infection, and even renal loss. Delayed renal bleeding can occur up to several weeks after injury, but usually occurs within 20 days, 21 days. Perinephric abscess can be there. Hypertension, the the basic mechanism for hypertension in renal trauma is renal vascular injury leading to stenosis or occlusion of the main renal artery or one of its branches. It's called gallbladder kidney. Compression of the renal parenchyma with the extravasated blood or urine is page kidney. Post-trauma AV fistula in these instances, the renin angiotensin axis is stimulated by partial renal ischemia and resulting in hypertension. This is the algorithm for management of renal trauma. If patient is stable, if non-visible hematuria and visible hematuria, in non-visible hematuria, if patient is stable, observation is done, and if the mode of injury is rapid deceleration or major associated injuries are there, the CT scan done, and if there is active bleeding, angiography and selective angioembolization is done, and if there is no active bleeding, if the injury grade is 1 to 3 and observation bad rest serial hematocrit according to severity, and if the injury is grade 4 or 5, observation and with repeat imaging, if there is a persistent urinary leak, there is a degestant or perinephric drainage should be done. In unstable patients, if there is ongoing resuscitation with and multiphase CT and angioembolization, if it is failed, if the angioembolization is failed, emergency laparotomy done, and renal injury, pulsatile or expanding in the case of pulsatile or expanding hematoma, renal exploration, if renal exploration is done, and a few points about the pediatric renal trauma. Children are more prone to renal trauma as the kidney are lower in the abdomen, less well protected by the lower ribs and muscles of the flank and abdomen. Kidneys more mobile, have less protective perirenal fat, and are proportionately larger in the abdomen than in the adults. Hypertension is a less reliable sign, and significant injury can be present despite stable blood pressure. Children have a higher proportion of congenital renal abnormalities such as severe hydronephrosis or PUG obstruction, which in turn significant renal injury from seemingly minor trauma. Indications for radiological evaluation of children suspected of renal trauma includes blunt or penetrating trauma patient with any level of hematuria. It may be a visible or non-visible. Patients with associated abdominal injury, regardless of the finding of urine analysis. Patients with the normal urine analysis who sustained a rapid deceleration event, direct flank trauma, or a fall from a height. Now, ureteral injuries. The famous quote of Higgins is the venial sin is the injury to the ureter, the mortal sin is failure of recognition. The etiology of ureteral injury are external trauma, open surgery, laparoscopy, endoscopic procedures. Uncommon causes are intraoperative suture ligation, sharp incision or transection, devascularization or avulsion of ureter. Or it can be by a high-speed blunt trauma and penetrating stab or gunshot wounds. Ureteral trauma accounts for 1 to 2.5% of urinary tract trauma. Iatrogenic injuries during open laparoscopy and endoscopic procedure are responsible for the majority of cases. Ureteral injuries should be suspected in all cases of penetrating abdominal injury, although it occurs in 2 to 3% of cases. It should also be suspected in blunt trauma with significant deceleration as pelvic ureteral disruption can result. The distribution of external ureteral injury along the ureter varies between series, but it is commonest in the upper ureter. Gynecological operations are the most common in causes of significant iatrogenic trauma. Laparoscopic hysterectomy is the most common cause of ureteral trauma. Is the CT showing the medial extravasation of the contrast material in a patient with a renal pelvic laceration? Symptoms of ureteral injuries are flank pain, fever, ileus, abdominal distension, and urinary fistula. The grading of ureteral injury by American Association for Surgery of Trauma. Grade 1, the hematoma. In grade 1, hematoma, contusion or hematoma without devascularization. In grade 2, less than 50% transaction. In grade 3, more than 50% transaction. In grade 4, complete transaction with less than 2 centimeter of devascularization. And in grade 5, avulsion of ureter with more than 2 centimeter of devascularization. Hematuria is the non-specific indicator of ureteral injury. Absence of hematuria results from the adynamic ureter and partially transected ureter or a complete ureteral transaction. By Campbell et al., 25 to 45% cases after violence do not demonstrate even microscopic hematuria. High index of suspicion is required. Intraoperatively, trajectory of the knife or missile is carefully followed. Ureteral exploration in all cases of potential injury. Intraoperative inspection of retroperitoneum, most important means of diagnosing ureteral injury due to in penetrating trauma. Methylene blue test can be done in suspected ureteral or renal pelvic injury. 1 to 2 ml of methylene blue dye injected directly into the renal pelvis with a 27 gauge needle to confirm the diagnosis. Imaging study by excretory urography. In ureteral injury, like renal injury, difficult to detect. IVP is often unhelpful and proving non-diagnostic in 33 to 100% of the time. Intraop one-shot pylography is still recommended to detect the ureteral injury and to assess the functional status of the contralateral system. In this IVP, showing the extravasation of the contrast material. CT ureteral injuries are difficult to diagnose on the CT scan. Delayed images are must, and the findings are medial extravasation of contrast material or non-opacification of the ipsilateral ureter. RGP, most sensitive radiographic test for ureteral injury, used in some center as a primary diagnostic technique. Delineate the extent of ureteral injury seen on CT scan or IVP. It also allows the simultaneous placement of ureter stent. The management of ureteric injury repair, the principles are mobilize the injured ureter, sparing the adventitia, not to devascularize the ureter, and debride the ureter liberally until the edges bleed. Repair ureter with spatulated, tension-free, stented, watertight anastomosis. Retroperitonealize the ureter by closing peritoneum over it. With the severely injured ureter, by blast effect or concomitant vascular injuries and other complex cases, consider omental interposition to isolate the repair. In ureter injury, if it is diagnosed immediately, in a stable patient, immediate repair can be done, and in unstable patient, damage control nephrostomy, PCN should be done, and the patient followed. If there is a delayed diagnosis, PCN or a DJ stent must be put, and a patient followed. When a stricture form, if there is upper then stricture form, and if there is no stricture, then patient safely followed up. If there is a structure formation there in upper one third, end-to-end, the options are end-to-end anastomosis, ureterostomy, ureterocalicostomy. If there is a middle one third of ureter is involved, end-to-end anastomosis, ureterostomy, or Boari flap can be done. And in lower one third, psoas hitch can be done. Uh, if there is a failure of with these type of surgery, if there is a long segment stricture, oral graft, ureteroplasty, intestinal interposition, and autotransplantation of kidney can be done. This is the ideal transposition In ileal transfusion, a healthy viable segment of distal ileum with vascular arcade is collected after side-to-side stable anastomosis. The proximal segment of ileal loop is opened and ureter is spatulated. Full thickness of ureter is pulled through a hole made in the anti-mesenteric border of the ileum and sutured over a stent. Seromuscular suturing is done. The Monty procedure, the short segment of bowel is separated and formed in a long, thin tube for uteral reconstruction. Ileal interposition is not suggested for acute repair of uteral injury, but rather would be used in the delayed or staged repair. Distal end of the ileal loop is opened and pulled over the stent through an incision over bladder, dome, and mucosal suturing is done. Seromuscular sutures done and ileal continues suture to the psoas fascia to reduce tension on the anastomosis due to gravity. Bladder drainage is done for 10 days. This diagram is illustrating the Monty procedure. It can be done by double Monty, triple Monty to the length needed for ureter. Uretero in lower 1/3 injuries, direct reimplantation of the ureter in the bladder can be done by ureteroneocystostomy, and there is a second photo is for psoas H, and the third one is the transureterouterostomy, and the ureterouterostomy, also called end-to-end repair. In psoas is the low oblique incision given, and the bladder is stressed and fixated to the psoas muscle. This image is showing the Boari flap, a tube made by the bladder dome. This is a mucosa ureteroplasty is an option for long segment ureteral injury, especially after a previous failed reconstruction. As an alternative to autotransplantation, the overall success rate is 90%. In intraop recognition of minor ureteral injury, the stent can be placed, and if there is a major ureteral injury, primarily stented ureterostomy, psoas H, Boari flap, or with or without kidney mobilization are the options. Ureteral stent should be put for 6 weeks and followed up by RGP and stent removal or replacement as needed. If it is failed, consider endoscopic methods like laser, exercise, or balloon dilatation of the ureter. In post-operative recognition of the ureteral injury, CT with contrast with RGP and if it is a minor injury, stent should be put for 6 weeks and the patient is followed. If there is a major injury, attempt a RGP and stent replacement. And if it is failed, a PCN placement. Thank you.
Thank you, KESHAV. So, again, a very important topic, not only from theory point of view, but practical aspect also. We all know upper urinary trauma, not very uncommon. Renal injuries are very common with both blunt injury and penetrating trauma. It accounts for almost 1% of all traumas. And usually the young males are more involved, right? So whenever a patient comes of trauma in the emergency, what do you do? So if there is a blunt injury abdomen, you have to actually, once you have resuscitated the patient, then you try to get a fast examination. So there's a very important thing. This has happened. Every trauma unit does have that kind of a facility that is focused assessment in in sonography in trauma, right? So that is very important to find out. Almost 2/3 of the patients can be actually assessed with this, though 1/3 of the patients can miss injuries of retroperitoneal hematoma or other injuries. right? So the most important thing is this, right? So doing a fast examination, and then definitely you take a proper history of the patient after proper resuscitation also. So again, in the history, you remember the word ample, right? So ample is A for allergic, any history of allergies, M for history of medications, what medications the patient had been taking. So you have to ask either the patient or the patient's attendant, right? Right? P for past surgical and medical history. L for last meals, when the patient had taken his last meal. And E is for events, what events happened before the injury. So ample, any patient of trauma, you should take this proper history. And then you do a physical examination of the patient, right? So if there's a blunt injury abdomen, and then you have to take the mechanism of injury. How did the injury happen, right? It could be due to the fall, it could be due to deceleration injury, right? And it could be due to penetrating injuries, so what stab wounds or the uh, course of the bullet missile, if it's a gunshot or a pistol injury. So this is very important while taking the history. And then on physical examination, yes, you see the vitals and everything and examine the whole body. And then if you have a history of blunt injury abdomen, then you see about the various signs. You know? Like if the patient had a deceleration injury, a car, there could be a seat belt sign, right? Seat belt sign, which there is a bruise over the chest, which can result in injury to the chest and abdomen as well. Then there are various signs, though they are not very kind of appropriate, but there are various signs that you must remember when you are seeing the abdomen and the back. So the one is sign is called the flank. If you find the flank ecchymosis, it's called Gray Turner sign. Right? If you have a periumbilical bruise, it is called colored sign. Right? If you have inner thigh bruise, it is upper inner thigh. That is called Fox's sign. And there's scrotal bruise, then it is called Bryant's sign. So these are various when you see on physical examination, right? So you examine the patient properly, physically, and then investigate them. So major important investigations, the blood investigations you have to send for CBC, serum electrolytes, etc. Also things. And you do always a chest X-ray and a pelvic X-ray. These two X-rays are very important whenever a patient of trauma comes. When you have a history of fall or accident, chest X-ray for the chest injuries and X-ray of the pelvis to rule out fractured pelvis. And then how do you see the pelvic instability in a trauma patient? So pelvic instability, compression test, which will tell you about the tenderness, a crepitus can be present, or you can see abnormal movements, the pelvic. But that has to be done by a very senior person so that you don't injure further patient, right? So you have to do it very carefully, these examinations. And then the urine examination for presence of microscopic hematuria. If the patient is having gross hematuria, it doesn't make much sense, right? So all these things are very important. So if the patient is unstable, the fast examination will lead you to the exploration of the patient. Patient has to be explored immediately. You can't send the patient to CT scan if the patient remains unstable, right? So on exploration, then you usually diagnose this renal injury or ureteric injury. If the patient is stable and you have known that the renal functions are normal, etc., then you can patient that definitely the actual protocol is a CT urogram where you can actually grade the renal injuries and try to see whether there is a ureteric injury also. Right? So this is very important again. Then how do you suppose the patient has come and you have been called it's a retroperitoneal hematoma, or on CT scan you find a retroperitoneal hematoma. How to judge what kind of injury could have resulted in retroperitoneal hematoma and how to treat them, right? So there are three zones. Very important, you must remember the three zones of retroperitoneum. Zone 1 is the central retroperitoneum from diaphragm to the bifurcation of aorta. So that tells you that the injury is usually to the major vessels, aorta, IVC, or origin of the renal vessels, right? Or the spinal injury sometimes. And then the zone 2 is the perinephric on the lateral side, two perinephric spaces, right? Lateral spaces from diaphragm to the bifurcation of aorta. And zone 3 is from bifurcation of the aorta below, right? So that is very important to guide the treatment and exploration also. So penetrating injury, zone 1, always explore. Blunt injury, zone 1, always explore because there is a chance of vascular injury, aorta or vein, IVC, etc. Or the origin of major vessels, right? Zone 3, usually if it's a penetrating injury, always explore, right? And zone 2 is if there is a retroperitoneal hematoma, you know, in zone 2, when there is a perinephric hematoma, if you try to explore every perinephric hematoma, you would land up in nephrectomy. So it has to be judged very properly. So what is the judgment? What are the indications? One is, as I said, expansile, if the hematoma is expanding. Secondly, pulsatile hematoma, right? And thirdly, if you're suspecting ureteric injury. Right? Fourth, if you are suspecting a colonic injury. So colonic injury should always be, right? Similarly, ureteric injury should be, if suspected, should be repaired. So when do you suspect ureteric injury? So ureteric injury is suspected, but particularly if there's a penetrating injury, and you think the course of the missile was through that region. So always explore, right? If post-operatively a stable patient develops ileus, flank pain, fever, sepsis, always have a suspicion about ureteral injuries. Right? Or on imaging study, you find there is kind of a medial extravasation, or the ureter is not seen, right? Or there is extravasation through the ureter or at the pubic junction, or there is a severe deceleration injury. Again, suspect there could be avulsion of the POJ. This is what happened with daughter of Diya Kumariji, right? So this is again very important. When to explore? So never explore a retroperitoneal hematoma if it is stable, even with grade 5 injury. Not necessary that even every grade 5 injury has to be explored. So high grade injuries, if they are stable, if it's not expanding, no pulsatile hematoma, don't suspect ureteric injury. It should not be explored. Otherwise, you will land up in nephrectomy. So how do you explore? The best way, if there's an expansile hematoma, usually, as he said about going laterally, it's very difficult to go through the hematoma and reach the hilum, right? So ideally, you should reflect the mesentery of the bowel, small bowel, and go directly on the aorta and IVC, and take kind of a control of the vessels there at their origin. Right? Once you take a control of the vessels there, then you can explore. Right? So if you think it is repairable, you will repair them. If not repairable, you will immediately ligate the pedicle there, because through the hematoma, it is almost impossible to find the hilum. Right? So when do you actually kind of intervene in renal injuries? So these are the injuries where we have to explore the retroperitoneum, right? As I said, post-operatively stable patients have developed ileus, flank pain, etc. You have to be there should be a strong index of suspicion of ureteral injury. Then if there are CT images, if you find the medial hematoma, there might be higher injuries. If there is kidney is not visualized on that side, or if there is a kind of a urinary extravasation. right? So if there is a urinoma formation, etc., you should have to drain the urinoma. If there's a large hydronephrotic kidney, you may have to, because delayed post, you could not probably detect it in the early period. You have to put a percutaneous nephrostomy, or you can do a stenting, right? So again, uh, the CT is important. If necessary, we can do an angiography to rule out the various renal pedicle injuries. Right? Or you can do a retrograde pyelogram also to rule out ureteric injuries. And CT scan, as I said, can be done sometime to know the exact function of the kidney in the postoperative period. So you know what function it has been, or in the follow-up of these patients. So renal injury is very important, how to manage them, because they heal very well. Majority. We have a study where we have seen even grade 4 injuries heal very well, and you would not be able to actually, after 1 or 2 years, the whole kidney appears to be normal on the CT follow-up CT scan. So it's very important how to manage these injuries. I think that's it in brief. If you have any query, or the audience or the people who have joined us as any query, please let me know. Otherwise, we will go ahead with the MCQs. So, which of the following are mechanisms of injury or physical examination finding concerning for a potential blunt renal injury? Significant blow to the flank, lower rib fractures, significant flank ecchymosis, a fall from a third-story window, all of the above. So all of this. So all can have lower rib fractures, can actually just go and pierce the kidney or the ureter and cause injury. Flank ecchymosis is a sign for injury, and a fall from third story window, definitely. Yes, that could cause injuries. Yes. What is the best option for repair of mid-ureteral transection after a stab wound in a stable patient? Ureterotomy, transureterotomy, Boari flap, nephrectomy, cutaneous ureterotomy. Yes, so if it is a just clean-cut transection of the ureter or the mid-ureter, you just kind of refresh the margins, make a spatulation on the two sides, and slightly mobilize the ureter on the two sides, and then you can do a ureterotomy. I think that's a valid option. When ureterotomy is performed, which of the following is required? Post-operative interposition. Post-op, no. So intraoperative interposition of momentum, post-operative nephrostomy tube, spatulated watertight repair over a ureteral stent, non-absorbable sutures, intraperitonealization of ureteral anastomosis. C. Spatulated watertight repair. So non-absorbable sutures are not required. Absorbable sutures are good enough. So post-operative nephrostomy, not required. So intraperitonealization of ureteral, why should you do intraperitoneal? Yes. Which maneuver is a common cause for ureteral injury during stone basketing? Ureteroscopy without dilating the ureteric orifice first, ureteroscopy in non-dilated system, use of holmium laser, pulsatile saline irrigation to assist visualization, persistence in stone basketing attempts in the face of ureteral tear. E. So stone basketing is almost obsolete nowadays. Nobody does off stone basketing. It used to happen previously. So if during a stone basketing, so if you persist, if you're persistent in trying to remove the stone, then that is the cause, right? So nobody does that nowadays. Which of the following is a contraindication to transureterotomy for repair of significant lower ureteral injury? History of urolithiasis, history of ureteral trauma, morbid obesity, neurogenic bladder, thoracic spine fracture. Urolithiasis. So it would be difficult for the stone to pass. Huh? Right. So transurethral tracheostomy is the last option. Usually, if it is a low aortic injury, why don't you just reimplant with sausage or body flap, right? So that should be the last option, because another thing is important is if there is an anastomotic stricture, stenosis, then both the kidneys would be hampered, right? So you have to be very careful doing transurethral tracheostomy. What is the best treatment for a short mid-urethral contusion caused by high velocity bullet? Observation, ureteral stent placement, transurethral ureterostomy, excision, and ureteral ureterostomy. Oversee the contusion with healthy ureteral tissue. Excision. Well, best to short mid-ureteral contusion caused by high velocity. So always there is a chance of ischemia and all that developing. So if you leave them as such, they may develop a problem. Yes. Which imaging technique is most useful for detecting ureteral injuries in the stable trauma patients? CT of the abdomen pelvis without the use of contrast, CT of the abdomen with IV contrast with immediate images, with immediate and delayed images, IVP, and direct renography. So always you have to get a delayed image. So only in patients who are unstable, you get a one-shot IVP with a delayed image at 10 minutes, right? So otherwise, in stable patients, CT urogram with delayed images should be the best option. Which of the following statements is true about ureteral injuries during laparoscopy? The total number of injuries has stayed steady over the years. Surgery for endometriosis greatly increases the risk. Bipolar cautery used during tubal ligation eliminates the risk. Most ureteral injuries are recognized immediately. Indigo carbon dye injection eliminates the risk of injury. D. B. Surgery for endometriosis. So the total number of injuries has definitely decreased over the years as the experience has gained. Early laparoscopic surgeons used to make more injuries. Endometriosis, because of the pelvic adhesions, definitely there is a chance of more injury. Bipolar cautery, though reduces, but it definitely doesn't eliminate the risk. Most ureteral injuries recognize no major. Many of them are missed while doing the surgery. And indigo carbon dye cannot eliminate the risk of injury death. Yes. A 42-year-old man had a CT scan 36 hours after a motor vehicle accident. The most likely diagnosis is. So, what do you see here? On the right side. So, don't see the nephrograph phase here, isn't it? On the right side. And what else? What else? Huh? On the right side, no optic. So ureteral injury, segmental renal artery transection, main renal artery occlusion, UP junction disruption, and traumatic renal vein occlusion. See? Because you can't see any dye going into the kidney, right? So ureteral injury, there should have been extravasation of urine. Or sometimes the ureter will not, we don't have all the films. Segmental renal artery transection, then only the part of the kidney would be occluded. Main renal artery and UP junction obstruction, the kidney will be higher, dilated, and disruption. Rather, there will be extravasation, so medial collection. Traumatic renal vein occlusion, thrombosis, renal vein thrombosis, all that may not show, but what it would show. So can you see what is this? Is that the artery? Right? What is this? Hmm? Samit? So usually, if there's a renal vein thrombosis, there's a halo kind of a here around this kidney, right? So probably this is a renal artery. complete absence of enhancement of the entire right kidney, which is caused by intimal injury, and then main renal artery occlusion. Segmental occlusion would cause abnormality only in the portion of the right renal nephrogram. Urinary injury and UPJ deception may cause delay in the nephrogram, but not complete absence of enhancement. I think that's it. If anybody has any question, please, residents, faculty, or anybody. Otherwise, we will wrap up the session. Thank you. Thank you once again, everybody.